So in the last part of the odontogenic cyst, we were studying about the radiological features of OKC. So as I told you, it is mostly seen in the posterior body or in the ascending ramus of the mandible. 50% of the cases you will see in the ramus region. Now coming on to the periphery and shape, it demonstrates as a well-defined round or ovoid radiolucent area with smooth and often corticated margins. Sometimes it may have the scallop margins. So internally, mainly it is radiolucent. It is usually unilocular and its presence, and you will see the presence of internal septa, which gives a multilocular appearance. Now it causes minimal expansion. It grows along the internal aspects of the jaw. ये आपका only cyst है जो within this jaw grow करती है. Rest of the cyst आपका throughout the jaw grow करेगी, but ये आपका within that area ही grow करेगी. Now it can sometimes affect the complete mandible without causing any expansion. It can displace and resolve the teeth, but to a slightest extent. Now, when it is multilocular and specifically it is located in the third molar area, it may be confused as the ameloblastoma. So, इसका सबसे पहला differential diagnosis आपका आता है ameloblastoma, followed by the dentagelous cyst. Now, as you can see in this picture, ये आपको एक unilocular cyst है, but इसमें आपको यहाँ पे you can see septas are present. So, it is visible as a multilocular cyst. Now, sometimes inferior alveolar canal may be displaced inferiorly. In the maxilla, this cyst can invaginate and occupy the entire maxillary sinus. And unerupted teeth is involved in the lesion, that is 20 to 40% cases में आपका unerupted tooth involve होता है. Radiographically, sometimes you may confuse it as a dentagerous cyst also. Now, it can cause perforation of the bone. Pathological fractures may also occur. Now, on aspiration, this cyst usually consists of a thick yellow, viscous or cheesy material. That cheesy material is a keratin, which is derived from the epithelial lining. In this picture, you can see this is the CT scan of a odontogenic keratocyst. इसमें आप देखो उसने पूरा का पूरा क्राउन इन्वॉल्व किया हुआ है द थर्ड मोलर रीजन एंड इट फिल्स द मैक्सिलरी साइनस आल्सो. ये देखो मैक्सिलरी साइनस में आपका सिस्ट इन्वॉल्व हुआ है. Now, histologically, odontogenic keratocyst wall is usually rather thin unless superimposed inflammation is present. इसकी epithelial lining भी बहुत thin होगी अगर inflammation नहीं है. Epithelium आपकी इसकी कैसी होगी? Stratified squamous epithelium. 80% of the cases show parakeratinized and 20% of the cases show orthokeratinized. इसीलिए जब इसको 2017 में WHO ने रिक्लासिफाई किया था अपनी क्लासिफिकेशन को, तो उन्होंने जब इसको पहले ट्यूमर में इसको प्लेस कर दिया था इंस्टेड ऑफ this cyst, they says कि नहीं इसके सारे features as a tumor resemble करते हैं, so we classify this as a keratocystic odontogenic tumor instead of odontogenic keratocyst. But later in 2017 they again classified it back into the cyst, and in that case they reclassified it as parakeratinized odontogenic keratocyst and the orthokeratinized odontogenic keratocyst. So 80% of the cases are your parakeratinized one and 20% cases are your orthokeratinized one. So epithelium is usually corrugated, rippled or wrinkled. It is 6 to 10 cell layers thick. You will see no retipex. Now the basal layer consists of columnar to cuboidal cells or mixture of the both. A prominently palisaded polarized basal cell layer often described as a picket fence or Thompson appearance. So this is the characteristic feature of the odontogenic keratocyst. आपके epithelium कैसे होगी? Thompson और picket fence appearance कैसी होती है? अगर आपने मूवीज वगैरह में या किसी उसमें जहाँ पे क्रिश्चियंस अपनी बॉडीज रखते हैं, वो अगर वो देखा होगा तो उसके ऊपर वो अपना एक वॉल का एक स्ट्रक्चर फॉर्म कर दैट इज योर टोम्बस्टोन अपीयरेंस. The nuclei of the columnar basal cells in the parakeratotic lining tends to orientate away from the basement membrane. इसीलिए आपको क्या है, न्यूक्लियस अवे फ्रॉम द बेसमेंट मेम्ब्रेन है और वो एक ही लाइन में है. So that is the palisaded one. And in majority of the cases it is intensely basophilic, means वो dark blue color का आपको न्यूक्लिया दिखेगा. Desquamated keratin is present in many cyst cavities. The cells superficial to the basal layer, they are polyhedral and they often exhibit intracellular edema. Now, sometimes mitotic figures are found in the basal layer and they are more frequent in the suprabasal layer. Then the attachment between the epithelium and connective tissue capsule tends to weak, and in many cases separation occurs. The epithelium is thin and mitotic activity is present. Therefore, OKC grows in the neoplastic fashion, not in response to the interference. सो दिस इज द वन इंपॉर्टेंट रीजन कि उसकी एपिथेलियम थिन होती है, माइटोटिक एक्टिविटी बहुत ज्यादा होती है। सिस्ट के केसेस में माइटोटिक एक्टिविटी इतनी नहीं होती। माइटोटिक एक्टिविटी कब बढ़ जाती है? जब आपका स्टिमुलस बहुत स्ट्रांग होता है। तो जब हम कोई ट्यूमर देखते हैं तो वो ग्रेड 1 से ग्रेड 2 या ग्रेड 3 में जाता है, वो कैसे पता चलता है? यूजुअली 1 to 2 माइटोटिक फिगर्स आपके, आप एक नॉर्मल एपिथेलियम भी चेक करोगे उसमें होंगी, बट मोर देन 5 और मोर देन 10 अगर माइटोटिक फिगर्स आपको एक ही एरिया में दिख रहे, दैट इज द न्यूप्लास्टिक एक्टिविटी। वहां पे कुछ ना कुछ न्यूप्लाज्म या कोई ट्यूमर ग्रो कर रहा है। तो दैट्स व्हाई हमने इसको, फर्स्ट रीजन हुआ था पीटीसीएच जीन, सेकंड इसके अंदर माइटोटिक एक्टिविटी बहुत इंक्रीज हो रही थी, इसलिए हमने इसको रीक्लासिफाई किया था। So those who are doing their MDS or they who are preparing for the NEET exam, this is the most important question. That is the reclassification of OKC to KCOT and then went back again to OKC. तो आपके उसके reasons क्या है? सबसे पहला PTCH gene. The second reason is the neoplastic activity. Now, coming on to the connective tissue, connective fibrous capsule of the cyst is usually thin. Then epithelial connective tissue attachment is very weak and it tends to separate from each other in many areas. हमें यहाँ पे बहुत सारे डॉटर सैटेलाइट सिस्ट भी देखने को मिलती है. The connective tissue wall often shows islands which is similar to the lining of the epithelium. Now rarely हमें इसमें क्या देखने को मिलेगा? We'll see the cholesterol clefts, melanin pigment, hyaline bodies, mast cells and mucous metaplasia. Now, in the presence of intense inflammation, the adjacent epithelium loses its keratinized surface. It may thicken and develop vertex or may ulcerate. So, as you can see, this is the epithelial lining with 6 to 8 cells thick with the hyperchromatic. ये आपकी epithelial lining है, ठीक है? आप देखो ये न्यूक्लियर कितना हाइपरक्रोमैटिक है, पेलिसेडेड मींस बिल्कुल एडजेसेंट लेयर में आपका प्रेजेंट है. सी दिस इज योर कोरुगेटेड एपिथेलियम. कहीं कहीं से देखो आपके एपिथेलियम में ब्रेक्स है. एपिथेलियम में कंटीन्यूअस एपिथेलियम नहीं है, लाइनिंग इसकी पैराकेराटिनाइज्ड है. ये बेसल सेल आपकी पॉलीहेड्रस सेल्स है. ये देखो इसे बोलते हैं पिकेट फेंस ऑफ पेरेंट्स, कि एक के बाद एक के बाद एक ही लाइन में अरेंज है. The apparent islands of epithelium and small startlet or daughter cyst actually represents the end of the folds. मतलब जहाँ पे आपकी epithelium line fold कर जाती है, वहाँ जहाँ उसका end होता है, तो हम उसको बोलते हैं they appear as a small satellite or daughter cyst. Now the lining of these cysts are very commonly folded. Sometimes the lumen contains lots of keratin, sometimes you see very little keratin. Now taller they suggest that the keratinizing cysts have valuable protein levels. इसमें protein level कितना होता है? That is 3.5 grams per 100 ml, and non-keratinized cysts were in range of 5 to 11 grams per 100 ml with the mean of 7.5 gram. ये दोनों पॉइंट्स आपके लिए बहुत इंपॉर्टेंट है, those who are doing for the MDS. See, this is again a diagram of odontogenic cyst. यहाँ पे देखो कहीं कहीं पे आपका सेंट्रल एरिया ऑफ पोस्टल लाइनिंग लॉस हो चुकी है. There is no connectivity between epithelium and you can see chronic cells है यहाँ पे. Inflammation chronic है. Now the variant of OKC that produce only orthokeratin act differently rather than the OKC. They are almost found in association with the dentaginous cyst around the third molar. They are less aggressive than the parakeratinized one. They are more common in the second to fifth decade. They do not have hyperchromatic basal layer. The basal layer इसमें flattened होती है. They are not associated with the basal cell nevus syndrome. The treatment, coming on to treatment, it should be surgically excised. The complete eradication of the cyst may be difficult. क्यों? Because of all of the cyst बहुत thin होती है, बहुत friable होती है, तो ये बहुत जल्दी fragments में टूट सकती है. Secondly, it causes perforation of the cortical bone and this complicates the total removement. तो 5-year follow बहुत इंपॉर्टेंट होता है इसका. मल्टीपल अगर हमें बहुत सारी ओके से दिखती है तो वी शुड रूल आउट फॉर दी बेसल सेल नेवस सिंड्रोम एंड बाइफिडियम सिंड्रोम. Now, the most important feature is the recurrence rate. OKC is the cyst which has the highest recurrence rate. The keratocyst enucleated one piece recurrent less often than the cyst enucleated several pieces. The size does not seem to influence its prognosis after surgery. Now, no significant differences in recurrence rates was found because of the following three methods. हम लोग करते हैं इसका ट्रीटमेंट में क्या करते हैं? मास्कुलाइजेशन, then we go for the enucleation primary closure. Third is the enucleation packing open. Now, इसका recurrent rate इतना high क्यों है? Like that 20 to 60% केस में इसका recurrence rate high होता है. First, tending to multiply. इसमें इतनी सारी डॉटर ऑफ सैटेलाइट सिस्ट प्रेजेंट होते हैं कि इट इज़ वेरी डिफिकल्ट टू रिमूव ऑल दी सैटेलाइट सिस्ट और ऑल दी डॉटर सिस्ट, मे बी कोई एक सिस्ट रह जाती है जिसकी वजह से इट कैन रीअकर. सेकेंडली, इनकम्प्लीट रिमूवल ऑफ द लाइनिंग, बिकॉज लाइनिंग बहुत थिन, बहुत फ्रेजाइल होती है, जैसे अटैचमेंट बहुत वीक होती है, तो हम कंप्लीट रिमूवल लाइनिंग का नहीं कर पाते. कंप्लीट रिमूवल के लिए हमें बहुत सारे एरिया रिमूव करना पड़ेगा, विच इज प्रैक्टिकली नॉट पॉसिबल. थर्ड रीजन इज दी, अगेन इट फॉर्म फ्रॉम द डेंटल लैमिना रेस्ट, तो मे बी उनसे ये रीडेवलप हो सकती है. फोर्थ इज द प्रोलिफरेशन ऑफ बोथ बेसल सेल्स ऑफ द ओरल एपिथेलियम. अब इसके जो बेसल सेल्स होते हैं वो प्रोलिफरेट कर जाते हैं, तो इफ दे प्रोलिफरेट तो ये अगेन रीअकर हो सकती है. So differential includes dentagenous cyst, ameloblastoma, odontogenic myxoma, simple bone cyst, lateral periodontal cyst, and residual cyst. Whosoever, like if you are in your third year or you are preparing for the NEET or you are doing MDS, differential diagnosis is very, very, very important. Differential diagnosis is not only for the people who are doing for the oral path, even for the people who are doing OMDR or for the oral surgery as well. Because this बहुत important topic है. आपके पास कोई भी पेशेंट आएगा तो आप एकदम देख के तो आप भी नहीं बता सकते कि वो ग्रो कितना कर रहा है. तो यू हैव टू गो फॉर दी ओपीजी और फॉर दी आईओपी. तो आप जब भी लोगे आपके पास एक तो माइंड में पिक्चर होनी चाहिए. ओके, थर्ड मोलर रीजन में है तो ये पॉसिबल चीजें हो सकती है, तो आप उसी के अकॉर्डिंग आप उसको रूल आउट करोगे. आप एकदम स्पॉन्टेनियस ही नहीं कह सकते कि हाँ दिस इज डेंटेजियस और दिस इज ओकेसी. यू हैव टू फर्स्ट रूल आउट ऑल दी कॉजेस कि ठीक है ये है ये है ये है, सो इट कैन बी दिस और इट कैन बी दैट. तो डिफरेंशियल डायग्नोसिस याद रखना इज वेरी 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 इंपॉर्टेंट. Even for the third year students, Viva में we most commonly ask, okay, differential diagnosis of this. For the spotting also, we have given you the diagram. Next question we usually give is a differential diagnosis. आप उसको क्योंकि sometimes it is very confusing to identify the slides. Sometimes they all look similar. For the students, they usually look like pink and blue only, or pink or purple only. So differential is very, very important. Now coming on to the syndrome associated with OKC, it's a jaw cyst basal cell nevus syndrome or bifidus syndrome. It is also called as hereditary cutaneomandibular polyposis or Goldenberg syndrome. Basically, it's a hereditary condition. It is transmitted as an autosomal dominant trait with high penitence and variable expressibility. It is caused by the mutations in the patch, that is PTCH, a tumor suppressor gene. Now, because of this tumor suppressor gene, we reclassify it as a KCOT. Now, coming on to the clinical features, cutaneous anomalies includes your basal cell carcinoma, your dermal cyst tumors, palmar pitting, palmar plantar keratosis, and dermal calcinosis. Dental anomalies includes your odontogenic keratocyst, mild mandibular prognathism, rib anomalies, usually bifid ribs, and vertebral anomalies. Now you can see this is a major basal cell carcinoma syndrome. It's a 52-year-old man with more than 100 basal cell carcinomas removed over the period of time. You can see this is the plantar pits. Small pits are formed. Then ophthalmologic abnormalities include hypertolerism with wide nasal bridge and congenital blindness. You can see ये bridge की आपका जो ये nasal bridge है, this is very very wide. Now, neurologic may includes mental retardation and dural calcification. Sexual abnormalities include hypogonadism in males and ovarian tumors in females. See, this is a small navel basal cell carcinoma syndrome. The oral manifestation includes the often develop early in life, so deformity and displacement of the developing teeth may occur. Sometimes they may not develop until middle age, even though basal cell skin tumors have occurred early in life. See, this is a picture showing histopathological picture showing navel based carcinoma syndrome. In this, odontogenic keratosis is showing numerous odontogenic epithelial rests in the cyst wall. See, ये बहुत सारे आपके यहाँ पे रेस्ट आपको दिख रहे हैं. Coming on to the treatment, several cases of ameloblastoma have developed in cyst of the syndrome. Hence, it is important to surgically remove the cyst and send it for the histologic examination. The next cyst is your dental lamina cyst of the newborn. It is also called as abscine pearls or bone nodules in the lamina cyst of the newborn. Now, dental lamina cyst of the newborn, they are multiple, occasional, solitary, superficial raised nodules on the edentulous ridge of the alveolar ridge of infants. You can see ये छोटे छोटे यहाँ पे आप देख रहे हो, Nodules, these are the dental lamina cyst of the newborn. They usually resolve without any treatment. Now they are derived from the rest of the dental lamina. They consist of keratin producing epithelial lining. Now, these absent pearls, हम इन्हें pearls क्यों बोल रहे हैं, क्योंकि ये छोटे छोटे आप you can देख लो कैसे ये white color के small small pearls की तरह form हो रहे हैं. That's why we call it as the absent pearls. They are cystic keratin filled nodules which is found along the mid palatine raphe. They are derived from the entrapped epithelial remnants along the line of fusion. जब आपका पैलेट डेवलप हो रहा होता है तो वहां पे कुछ रेमिनेंट्स रह जाते हैं. तो समटाइम्स उस रेमिनेंट में फ्लूइड फिल्ड होने की वजह से वो आपका डेवलप तो कर गया, दैट हैज इनक्लोज्ड. जब वो इनक्लोज हो जाता है तो वहां पे लाइनिंग जो फ्यूजन वाला लाइन है वहां पे कुछ epithelial remnants ट्रैप हो जाते हैं. So they form these small absent pearls. Now these are also called as bone nodules. They are keratin fissures scattered over the palate. So they are usually formed along the junction of hard and soft palate and they are derived from the salivary gland structures. Coming on to the clinical features, when dental lamina cyst of the newborn it becomes large, it is visible as a small discrete white swelling of the alveolar ridge. See, अभी white swelling है इसीलिए हम इसको बोल रहे हैं absent folds. Now it may appear as a blanch as through the internal pressure. जब हम इसे pressure लगाएंगे तो ये blanch means extend करता है. Sometimes it is referred to as pre-deciduous dentation. They are usually asymptomatic. Histologically, they act as a two cyst. It consists of a thin epithelial lining with lack of retipex. Lumen is filled with desquamated keratin with occasionally inflammatory cells. And sometimes you will see dystrophic calcification and hyaline bodies of rastrum may be present. It doesn't require any treatment. It disappears by opening of the surface of the mucosa through disruption of the erupting teeth. जैसे ही आपका उस जगह पे जहाँ पे ये कहाँ फॉर्म हो रहा है, यूजुअली जहाँ पे टीथ नहीं है, ऑन दी प्लेन alveolar ridge. So जैसे ही आपका erupt होगा, it will go by its own. The next is the gingival cyst of the adults. Again, it's a small developmental odontogenic cyst of the gingival soft tissue which is derived from the cell rest of the dental lamina. It is again an uncommon cyst. It occurs either in the free or attached gingiva, as you can see. देखो यहाँ पे ये आपका free और attached gingiva, ये आपका attached gingiva है. यहाँ पे ये small सा cyst develop हो रहा है. That is your gingival cyst of the adult. Now it contains the lining of the embryonic epithelium of the cuboidal cells. Distinct focal thickening similar to the lateral periodontal cyst is present. Coming on to the etiology, it arises from the cystic transformation of dental lamina or the glands of the or rest of serosin. जो आपका यूजुअली रूट फॉर्मेशन होता है तो कुछ वहाँ पे उसके रेमिनेंट्स रह जाते हैं. तो उसके अंदर जब कभी कभी उन रेमिनेंट्स में सिस्टिक ट्रांसफॉर्मेशन होता है, दैट कॉजेज योर gingival cyst of the adult. Now it can again arise from the traumatic implantation of the surface epithelium. Therefore, we sometimes we do not call it as a true odontogenic cyst. Coming on to the clinical features, it occurs at any age, mostly in the adults over 40 years of age. Mean age is 33 to 40. It is located similar to the lateral periodontal cyst, that is mandibular bicuspid and cuspid incisor region. It occurs as a small, well-circumscribed, painless swelling of the gingiva, which sometimes may resemble as the mucosa. Now, the color of the cyst is as same color of the mucosa. It is usually larger than 1 centimeter in diameter and occurs in the free attached gingiva, sometimes occurs in gingival papilla also. Coming on to the radiographic features, since it's a soft tissue lesion, so we cannot see it on the X-rays. If it enlarges to a large size, अगर ये बहुत ज़्यादा बढ़ जाता है, like more than 2 or 3 centimeter, then we go for the superficial erosion of the cortical plate of the bone. Lateral periodontal cyst, sometimes we confuse other lateral periodontal cyst. तो कैसे दिखता है ये? As a radiolucent. अगर हमें कभी दिख भी जाता है, so it appears as a radiolucent. Histologically, again, it's a tooth, so it has a pathological epithelial line cavity which contains fluid. It can be unicystic or polycystic. Now, cyst lies free in the connective tissue of the gingiva. Inflammatory cells may or may not be present. As you can see in this picture, ये पूरी एक lining है, ये इसके epithelium है. See, this is in the high power. यहाँ पे आपको कहीं पे क्लियर सेल्स कहीं नहीं दिखेगी. ये एक एपिथेलियम जा रही है which is like a normal epithelium है आपका, उसके अंदर cells है, connective tissue है, just like a tooth cyst you can see. Now it has a lining similar to the lateral periodontal cyst. Epithelium can be single layer of flattened to stratified squamous epithelium. You will see glycogen-rich clear cells which may be present especially in the focal thickening of the lining. Then connective tissue wall may contain dental lamina rest and they are composed of glycogen-rich clear cells. Now, if it is traumatic or implantation type of cyst occurs, then you will see calcification or sometimes ectopic ossification may be present. Coming on to the treatment, we go for the local surgical excision. There are very rarely reoccurs and it has no neoplastic potential. Now, coming on to the next cyst, that is lateral periodontal cyst. It's a slow growing, non expansile developmental odontogenic cyst which derives from one or more of the rest of the dental lamina. It arises from the proliferation and cystic degeneration of the clear cells of dental lamina, which are in post functional state. Hence, it explains for the small size due to limited growth potential. Now, again, it's not a common cyst. It contains an embryonic lining of 1 to 3 cuboidal cells and distinctive focal thickening, that is plaque formation. It occurs in the lateral periodontal teeth. ये आपकी lateral periodontal position में form हो रही है between two teeth. This is your lateral periodontal cyst. So again, it can be confused with the gingival cyst of the adult. The differentials इसकी क्या क्या होती है? Inflammatory cyst और keratocyst. Clinically, it occurs in the adults, that is mean age of 50 years. एज वाइज ये रेंज करती है 22 to 85 ईयर. ऐसे ही आपका जो gingival cyst of adult था उसका मीन एज था 40 years. Otherwise, that starts from the 33 years to 50 years or 60 years तक की आपकी एज रहती है. Predilection मेल्स में ज्यादा. ओके, नाउ वन मोर थिंग. अब जितने भी सिस्ट पढ़ोगे ना, दे हैव अ मेल predilection. Whereas whenever you go for the salivary gland tumor, it has female predilection. Only they have few exceptions, but mainly salivary gland tumors have your female predilection, whereas cysts they have a male predilection. So again, it becomes very much important for you to remember कि आपके पास कोई केस आया है, so आप इसको ऐसे भी रूल आउट कर सकते हो कि whether the person is male or female. अगर male है, so okay, we can go for the cyst first rather than the tumors. Now location, 60% cases हमें मिलते हैं mandibular bicuspids में, then cuspid followed by the incisor area. 33% cases आपके maxillary lateral incisor के areas में होते हैं. इसके कोई साइंस और सिम्टम्स नहीं होते हैं. यूजुअली रूटीन एक्सरे में ये आपको डिस्कवर होता है. It is associated with the vital tooth. Now, if the cyst gets infected, it may resemble like the lateral periodontal abscess, even start draining. Radiologically, it appears as a radiolucency in the lateral surface of the root. Lesion is usually small, like around 1 centimeter in diameter, just like the gingival cyst of adults. It may or may not be well circumscribed. Most cases, they have a well-defined border with a thin layer of sclerotic bone. As you can see, radiolucent lesion है between the roots of a vital mandibular canine and first premolar. ये इसका enlarged view है. Now there is one more, so that is Botrytis cyst. It appears as a polycystic radiolucency, that is multilocular. Now histologically, it is lined with a thin non-keratinized epithelium, which is usually 1 to 5 layers thick and resembles like a reduced enamel epithelium. Now it has cuboidal or even columnar cells, which is composed the lining of this cyst. Now many of the lining cells they have a clear vacuolated glycogen-rich cytoplasm. Now this is the differentiating feature between your gingival cyst of the adult and the lateral periodontal cyst. The lining is incomplete as it easily sloughs away. The focal thickened plaques of proliferating lining cells often project into the lumen and some areas. Now, these are especially common in the Botrytis cyst. Rest of dental lamina sometimes found in the connective tissue and are composed of glycogen-rich clear cells. These are especially common in the Botrytis cyst. Now, as you can see, it shows the epithelial lining with focal nodular thickening. See, this is the epithelial lining with the focal nodular thickening. The papillary foldings of sometimes you see papillary foldings of the wall. That inflammatory cells may be present if it is secondarily infected. Connective tissue is again thick and fibrous, but it is not inflamed. The connective tissue subjacent to the epithelium exhibits a zone of hyalization. Now, Botrytis cyst is resembles like a cluster of grapes. As you can see, it's a gross specimen of a Botrytis variant. See, कैसा grape like आपको appearance दे रहा है with separate cavities. Treatment again surgical enucleation. We basically avoid extract the associated tooth because the tooth is fine, but the pathology is outside the tooth. So we try to just go for the first. We reduce the size of the cyst and we'll then surgical excision. If it is a botrytis variety, then we'll go for the increased risk for the reoccurrence. The next important cyst is your calcified odontogenic cyst, which is also called as keratinizing or calcific epithelial odontogenic cyst, or CEOC, that is calcified epithelial odontogenic carcinoma, and then Gordon cyst and calcified bone cell odontogenic cyst. Now, the lesion is unusual. Apart from your dentagerous and OKC, the third most common cyst is your calcified odontogenic cyst. The lesion is unusual in that it has some features suggestive of cyst, but also has many characteristics of solid neoplasm. Most arises centrally within the bone. It may occur peripherally in the soft tissue overlying the tooth-bearing areas. A unique odontogenic lesion was first described by Gordon in 1962 under the term calcific epithelial odontogenic cyst. इसीलिए हम इसे बोलते हैं COC, और इसीलिए हम इसे कभी-कभी Gordon cyst भी बोलते हैं, because Gordon was the person who described this cyst first. Although is widely considered to represent as a cyst. Now it's very rare and well circumscribed. It's a solid or cystic lesion derived from the odontogenic epithelium, which resembles follicular ameloblastoma, but it contains both cells in spherical calcification. Now, it may be associated with other recognized odontogenic tumors, most commonly your odontomes, adenomatous odontogenic tumor, and ameloblastoma. That's why it is divided into three subtypes. First is the simple unicystic type. Then 1B is a unicystic odontome producing type. Third is the unicystic ameloblastomatous proliferating type. So first we'll study about the simple unicystic type. It occurs in any, again it's a very important question. You can get it as a short one or as a long. Like you can get define and classify cyst and describe COC in detail. Okay. So in that you have to give classification, definition. You also have to mention about the part of the cyst. Then you will go for the calcific odontogenic cyst. Right? Maybe either intraosseous or extraosseous lesion. Epithelium of the cyst lining is chiefly leucoboidal or squamous, that is 2 to 3 cell layer thick. Focal areas of stereo reticulum and ghost cells may be present, and they also dentinoid may be present. There are हार्ट टिश्यू फॉर्मेशन इसमें नहीं होती. और इसका कैरेक्टरिस्टिक फीचर अभी हमने पढ़ा है, इसके अंदर गोस्ट सेल्स होते हैं और एक स्पेरिफिकल कैल्सिफिकेशन होती है. गोस्ट सेल्स इज अ कैरेक्टरिस्टिक ऑफ दिस लीजन. Basically, they are pale, eosinophilic, swollen epithelial cells that have lost the nucleus but show a faint outline of the cellular nuclear membrane. अब इसमें क्या होता है, आपका जो सेल्स होता है उसके अंदर कुछ भी नहीं है, उसका जितना भी eosinophilic मटेरियल था दैट हैज बीन लॉस्ट. बस आपको क्या दिखेगा, एक सेलुलर मेम्ब्रेन दिखेगी, एक न्यूक्लियस है उसका मेम्ब्रेन दिखेगा. हाउ डू यू सी अ गोस्ट? आपको गोस्ट जब आप देखते हो तो यू डोंट सी एंटायर पर्सन, यू जस्ट सी कि हाँ समथिंग इज देयर, आपको कुछ बाउंड्री दिख रही है या एक पर्सन की एक शैडो दिख रही है. Similarly, you will see in such cells. So that's why these cells are called as ghost cells. Their presence is not confined. Ghost cells है तो this doesn't mean that this is a COC. They can also found in ghost cells. आपको again it's a very important viva question, and for the NEET question, that where do you find ghost cells other than COC? You will see it in the ameloblastic fibrodontomes, complex and compound odontomes, and sometimes in the ameloblastoma. Now, ghost cells, they contain nuclear remnants of cytoplasmic organelles, and numerous tonofilaments. Ghost cells differ from normal keratotic squams that they are larger, they're often vacuolated, and remnants of the nuclear membrane are more prominent. This may be due to intracellular edema in the presence of dilated, degenerated membranous organelles. Now, ghost cell keratinization may be observed in your odontomas, ameloblastic fibrodontomas, and ameloblastic odontomas. The most observed ghost cells to make diagnosis of golden cyst. The second is the type 1 is first was the simple unicystic type, now the odontome producing type. It occurs between 10 to 29 years of age. It can be either intraosseous or extraosseous. Histologically, it unilocular cyst with the similar type lining of the type 1. In addition, they exhibit formation of calcified tissues in the cyst wall. Coming on to the third type, that is the ameloblastomatous proliferating type. It's an intraosseous lesion. Histologically, it represents ameloblastoma-like proliferation of connective tissue of the fibrous capsule as well as the lumen of the cyst. Now, there is one more type, that is the neoplasm-like lesion. It exhibits an entirely different structure which consists of ameloblastoma-like strands and islands of odontogenic epithelium which infiltrates into mature connective tissue. Again, in this, ghost cells are also present. Dentine-like structure is also found in contact with the odontogenic epithelium. It predominantly occurs in the later life, like in the 50s or 60 years of your age. It may be introstrous or extraosseous. It has high chances of recurrence and it is designated as a dentogenic ghost cell tumor. Now, in 1992, WHO classification includes this cyst and in all its variants and the category of odontogenic tumor. The COC represents two lesions, that is, it has a cystic lesion and a solid neoplastic lesion. So, a third malignant counterpart of neoplastic lesion was later on added in this category. Coming on to the clinical features, it's a not common lesion. It can occur at any age. So now, till now, we have seen that all the cysts have the male predilection. Now, COC has equal predilection, that is 1 is to 1. Now, primarily, it's an intraosseous lesion, that is 75%, and 30% cases are extraosseous. 60% cases occur in the incisors and the canine region. Now, you will see mainly in the second and third decade. The COC in association with an odontoma occurs in the younger patient, like in the 17 or 20 years of age. So as you can see in this picture, the anterior region has higher predilection, then in the maxillary canine region, followed by the mandibular third molar area, then in the mandibular second molar area, and then the maxillar third molar area. The symptoms, it's a slow growing cyst, it's painless, non-tender swelling of the jaws. Occasionally, some patient may complain of pain. Signs, you will see cortical plate over the expanding lesion may be destroyed and cystic mass may be palpable with patients reporting of discharge. अब इसका एक्सप्रेशन आपको कैसे मिलेगा? विस्कस ग्रैनुलर येलो फ्लूइड की तरह मिलेगा. Your teeth, adjacent teeth may be dispersed. Obviously, swelling जब grow करेगी तो adjacent teeth में disperse. Radiographically, COC that occurs centrally in the jaw is painless, expansile lesion, which is discovered accidentally on the routine examination. It is seen as a radiolucency or radiolucency with require the opacification, that is, when it is associated with the odontome, and expansion may be seen in some cases. The location, 75% of the lesion occurs in the bone, that's why it is intraosseous. Nearly equal distribution is between the jaws. Now, 70% cases occurs anterior to the first molar, which are associated with the canines and the incisors. Now, sometimes we see the pericorneal radiolucency also. So, coming on to periphery and shape, the central intrabony lesion, it appears as a radial lucid, usually well circumscribed. The margins it presents with variable margins, which may be sometimes quite smooth with a well-defined outline or irregular in shape with poor defined margins. As you can see, ये आपको यहाँ पे present है कितना well defined इसका margin है. This is your maxillary area. The internal structure is completely radiolucent. Variable amount of calcified radiopaque material are usually scattered throughout the radiolucency, which ranges from flex to large masses. So sometimes it may be appear as a multilocular. Now again, mostly cysts are unilocular except OKC. OKC can be multilocular and unilocular in same criteria. Now they may become very large lesions, may centimeter in diameter. Now, the surrounding structural effect causes associated tooth impairs its eruption. If it is associated with any tooth, तो उसका eruption थोड़ा possible नहीं होता. Displacement and resorption of roots may occur. Sometimes perforation of the cortical plate also occur. The central lesion usually occur as a unilocular, and if it is radio-opaque structure, it shows irregular calcification of tooth-like densities which may be present within the lesion in 1:3 or 1:2 cases के ratio में. Radiolucent lesion is usually associated with unerupted crown that is mostly in the canine. They may be as large as 12 centimeter. This is the very important thing to remember कि इसका size जो है वो सबसे ज़्यादा grow करता है, that is 12 centimeter. The root resorption or divergence of adjacent teeth is seen and it may resemble like your gingival fibroma, gingival cyst, or peripheral central giant cell granulomas. Historically, cystic, that is non-neoplastic variety, comprises 86-90% of all the COC. They may occur both extra and intraosseously. Most commonly, we'll see as a well-defined cystic lesion found within the fibrous capsule and a lining of odontogenic epithelium, that is 4 to 10 cell layer thick. Now, main features इसके क्या क्या है? The cystic lining shows proliferation to the point that it resembles like the ameloblastoma, that is columnar cells over which there are stellate and spindle cells in arrangement, that is suggestive of stellate reticulum. Within this, the proliferation of epithelium cells undergoes a characteristic ghost cell keratinization. Now, ghost cells are known as the eosinophilic altered epithelium cells characterized by the loss of nuclei with preservation of the basic cell outline. Now, we don't know whether it is form of abnormal or normal keratinization of odontogenic epithelium. Calcification within the ghost cell is common. Now, areas of eosinophilic matrix material shows which represents as a dysplastic dentine, that is dentinoid, which may be represent adjacent to the epithelial component. Now, in some cases, the epithelial lining proliferates into the lumen, so the lumen is largely filled massive with the ghost cell plus dystrophic calcification. The multiple daughter cysts may be present within the fibrous wall, as you can see in this picture. यहाँ पे बहुत सारे fibrous walls ये present है. So this is a histological picture of COC. यहाँ पे देखो ये ghost cells है. इनका सिर्फ एक न्यूक्लियर आउटलाइन रिटेन है, नथिंग एल्स. So this was all about your odontogenic cyst.